and the end of arterioles. So from action potentials to arterioles is the new material. Yep, there will be questions from the Unit 1 material. So there will be questions that have to do with graded potentials, for example. There'll be questions that have to do with membrane signal transduction. There'll be questions that have something to do with diffusion, I think. So, yeah, you do need to, and this is just the case in all health science programs. Not every place all exams are cumulative, but all information is in play, because you only go over things that considered essential knowledge. So, seems to me that there was one other thing that, Proctor, you were talking about this, so I think we kind of hit that. So from action potentials to arterioles, yes, the first unit material is in play. Obviously, there's going to be much more emphasis on the second unit material, but hey, there's things we've gone over that if you don't understand both graded potentials and action potentials, you won't be able to utilize that for the material that we're going over right now. So, and then today we will have the review of the cardiovascular questions, and I'll stick around and answer any other questions that you might have. So, let's get started where the next section, it's really kind of the next to last section of CV before we go on, and part of it is blood pressure regulation. Now, most of what we're going to talk about today, we've already talked about. We're just going to put it in action. We've already learned about control of heart rate, control of stroke volume. You've already learned about those things. So now we're going to see regulation of heart rate and stroke volume in a more dynamic atmosphere, okay? With a little bit more things going on. And then we'll see how regulation of the cardiac output along with regulation of total peripheral resistance helps regulate overall mean arterial blood pressure. So yeah, there's kind of a duplication of the notes I gave you today. Some of these slides are at the end of that last note packet. So a reminder that mean arterial blood pressure is a product of cardiac output times total peripheral resistance, and cardiac output itself, you can break that down into heart rate and stroke volume. So heart rate times stroke volume gives you cardiac output times total peripheral resistance, and that determines your mean arterial blood pressure. So if your body ever has to boost blood pressure up, it has some options. It can increase heart rate, it can increase stroke volume, it can increase total peripheral resistance. If your blood pressure needs to come down, it can impact any one of those. And usually it's several things at once. Several of these things at once. So the first thing we're going to talk about with how the body is, it's constantly monitoring your blood pressure. You know, some older folks that have hypertension, they take their blood pressure every day. Well, your body takes its blood pressure every second. It's taking its blood pressure every second in a number of ways to monitor how high is it, how low is it, do we need to do something about it? It gets back to homeostasis. If it's too high, what can we do to get it back down to normal? If it's too low, what can we do to get it up closer to normal? So there's the afferent and efferent limbs for homeostatic reflex loops, sensory, effector, negative feedback loops, just like we talked about in the first unit. Same thing for blood pressure. We have sensors, we have effectors, and then once you get things back into the normal range, everything turns off. That's negative feedback. So this goes along with everything we've been talking about. So one part of your blood pressure monitoring system are your arterial baroreceptors. Anytime you see baro, B-A-R-O, that means it is a mechanoreceptor, and it is specifically a mechanoreceptor that senses pressure. It senses pressure. So a baroreceptor, it is a pressure sensing mechanoreceptor. And we have these in several places in our arterial tree. Now, the function of these baroreceptors really notify our autonomic nervous system what to do. Sometimes your baroreceptors tells your sympathetics to turn on and your parasympathetics to turn off. Sometimes it's the other direction. So there's very close communication between your baroreceptors and your autonomic nervous system. Do make sure you look at these figures in the book. Now here's where you have a lot of these pressure sensing baroreceptors in many places throughout the body, but they are really elaborate here in your carotid sinus and also in your aortic arch. So these pressure sensing baroreceptors are found in very high concentration in these two places. So these are pressure sensing baroreceptors, and when blood pressure goes up, it mechanically perturbates those baroreceptors, and what do? They depolarize. They depolarize. And when they depolarize, you can see that, so the baroreceptors are found right at the sensory nerve endings of this neuron right here. And they're also found right here at the sensory nerve endings of this neuron right here. Okay? So, let's say if blood pressure is elevated, what's it do? It causes a graded potential, a baroreceptor sensory potential. If it's great enough, it'll activate this neuron and it'll send information up here to the brainstem. Let the brainstem know what's going on with blood pressure out here. Same thing here in the carotid sinus. These carotid sinus baroreceptors, sensory receptors, if blood pressure is high enough, it will activate them, and that will increase the rate of neural discharge. So here is what the nerve firing rate, and also this actually shows baroreceptor potential frequency. Yep, these things have receptor potentials that if they drive the axon to threshold, then you get nerve firing. So oftentimes on these graphs you'll see baroreceptor potential frequency or baroreceptor nerve firing rate. It would be the same thing. The potential leads to action potential, you call that nerve firing. And what do you see here? You see that if blood pressure goes up, if you draw a line, here is your normal blood pressure, mean arterial blood pressure. If somebody has blood pressure, say 120/80, it'd be about 93. So you go here and that would be that person just when their blood pressure is 120/80, that's its firing frequency right here. But if blood pressure goes up, the firing of those neurons from the aortic arch and from the carotid sinus, the frequency goes up. More action potentials per unit time, telling these brainstem centers in your medulla, hey, blood pressure is going up. Conversely, if blood pressure goes down, the nerve firing rate goes down. That too provides information to those medullary centers, the brainstem centers, saying, hey, blood pressure is going down. So blood pressure is being monitored 24/7, 360, well actually second to second. Every 60 seconds of every 60 minutes of every hour, 24 hours a day, 7 days a week. So constant monitoring of blood pressure, constant monitoring of blood pressure. And these blood pressure reflex centers here in the brainstem, they're getting this information all the time, in real time, letting these centers know what is blood pressure, should we do something about it? Do we need to increase a little bit? Do we need to decrease a little bit? I do want you to take a look at the slope of this curve right here. You notice, I hope you notice, that right here, the resting value is smack dab in the middle of the steepest part of that curve. What this means is, the steepest part of the curve is where we have the greatest sensitivity to changes in blood pressure. If that curve would be clear up here, you know, a whole lot of change in blood pressure, very little change in neural firing rate. But we're set up so that our mean arterial blood pressure, it sets this tone, and this curve, where our mean arterial blood pressure, it's just right smack dab in the most sensitive part of that curve. Small decreases in blood pressure, big decreases in nerve firing rate. Little increases in blood pressure, big increases in nerve firing rate. You notice that? That means we're very sensitive to changes right around our resting mean arterial blood pressure. Now, here's kind of the kicker. Here's kind of the kicker. These baroreceptors can reset. That curve, that entire curve, if somebody, for whatever reason, if their blood pressure is elevated for a period of time, they can undergo adaptation. Remember sensory adaptation? These things, unfortunately, can adapt. So if somebody has an elevated blood pressure for a period of time, it resets the curve over here, and guess what? It has a new set point. It has a new blood pressure set point that it tries to maintain. So if, for example, you know, early on in the semester I was on that drug prednisone, which can increase blood pressure in people. And I had been on it one time before, years and years ago, and my blood pressure was 155 over 105. And it went on for a couple of weeks, and it was scaring the dickens out of me. And it took a long time for me to get my blood pressure back down to normal, because my sensory receptors had started to adapt and reset. So people with, oftentimes people are undiagnosed hypertensives for a long period of time. You don't feel high blood pressure really. So if somebody's an undiagnosed hypertensive, their curve might be all the way over here. So clinically, you might have to do a lot of things, both non-pharmacologically and pharmacologically, to drop their blood pressure. But once their blood pressure is back to a safer, more normal level for a long period of time, oftentimes you can start weaning them off certain antihypertensive medications, because that's reset, and now that'll work for you. Yes?
So, yeah, with that, so in a kind of perfect situation, if you pull them back down after a while, then you should be able, if there's not other underlying.
It might take 1 or 2 years though.
Okay.
Yeah, I have a good friend, and so this is a one-person anecdote, but I mean, I actually have several of these one-person anecdotes. I think I mentioned briefly, he's a musician, and he inhaled a reed off his harmonica and caused pulmonary inflammation, so he very dramatically had to inhibit his inflammatory system. And so he was given very high prednisone for a long period of time. He had a genetic history of hypertension, so he was just triggered to reset, and he did. Now, it was 2 or 3 years of medication, and I think he's just on one antihypertensive medication now versus 3. And that's possibly because of a couple of different things. He's lost some weight. That has a huge impact, you'll see later, on blood pressure, but he probably over time helped reset those. So now they're working for him instead of against him a little bit more, and that's kind of what you want. You want your system working for you rather than against you. So here's a slide that, so the text, decrease mean arterial blood pressure, let's go in this direction, will decrease baroreceptor nerve firing rate to the brainstem centers, which, so if your blood pressure is falling, what do you want to do? You want it to go back to normal. So just think from what you already know. For the autonomic nervous system, what would increase heart rate? What would increase contractility? What would increase cardiac output? What would increase total peripheral resistance? Well, if you have a falling blood pressure, that decrease in baroreceptor nerve firing rate, up here, you have both parasympathetic and sympathetic control centers right here receiving this information. If you have a falling blood pressure like this says, that will stimulate your sympathetic nervous system and it will inhibit your parasympathetic nervous system. So just think what that would do, just with heart rate. If you decrease parasympathetics, heart rate goes up. If you increase sympathetics, heart rate goes up a little bit more. And since mean arterial blood pressure, one of the factors, one of the elements controlling it is heart rate, that right there can help you. That right there can help you. And it goes in the other direction too. All these things go in the other direction. So an increased mean arterial blood pressure will lead to an increase in parasympathetic, and it will lead to a decrease in sympathetic. So hopefully you have today's note packet, because in the other one I didn't have this slide. So here's that same curve. This is the baroreceptor nerve firing rate curve for blood pressure. And once again, the center point here would be at that person's resting mean arterial blood pressure. And what this is showing you is if baroreceptor nerve firing rate goes up, and that goes up when blood pressure goes up. So when baroreceptor nerve firing rate goes up due to blood pressure going up, so this causes that, causing this. So an elevation in mean arterial blood pressure will lead to an elevation in baroreceptor nerve firing rate. And what does that do? It causes sympathetic nervous system activation to go down. Goes the other direction too. If baroreceptor nerve firing rate goes down as a consequence of blood pressure going down, sympathetic stimulation goes up. So sympathetic nervous system neurons are firing more. Now let's look at parasympathetic. It's just inverse. It's just inverse. And sit back and think about this and go, boy, if I were to build a machine, this is exactly what I would do. So if blood pressure is going up, let's say blood pressure is going up, it's going from left to right. Blood pressure is going up, that means the nerve firing rate will go up. Well, that causes a reflex increase in parasympathetic nervous system outflow. So parasympathetic stimulation to the SA node does what? What does it do to your heart rate? It makes it go down. If it goes down, that in and of itself can help decrease blood pressure. The problem was blood pressure was too high. This is telling your brainstem centers it's too high. The brainstem centers turn on a mechanism. In this case, it's increasing parasympathetic nervous system discharge. And what does that do? That helps gets your one of the elements controlling blood pressure back down to normal. So sympathetic activation and parasympathetic activation, you can see they're inverse from one another. And that's the way it normally is. There are some quirky pathophysiologic things where sometimes they're going in the same direction, but that's not typical at all. It's not typical at all. So there's a lot of information here. How are you feeling about that? But step through it, that if blood pressure increases, that's going to increase baroreceptor nerve firing rate, and that is going to have a consequence on both sympathetic and parasympathetic. Okay? So, and I give you in text pretty much what I just went over, and yes, baroreceptors can reset their set points. Okay, so let's look at the regulation of mean arterial blood pressure with these elements: heart rate, stroke volume, total peripheral resistance. And let's look at the regulation of each of these elements. You already know this stuff. This is material we've already gone over, but I just want you to think about this using this equation. If you really understand this equation and these elements and what regulates them, you have a huge treasure trove of comprehension for regulation of blood pressure, both non-pharmacologically and pharmacologically. So let's look at how is heart rate regulated. Already know. Well, for example, sympathetics. Sympathetic nervous system regulates heart rate. You know, when you have an increase in sympathetic nervous system activity, that increases heart rate, that can increase cardiac output, that can increase blood pressure. And that's via beta-1 adrenergic receptors, isn't it? It goes the other way. I hope right below this, you draw in, if sympathetic nervous system activity goes down, heart rate will go down, cardiac output would go down, mean arterial blood pressure may go down. So the sympathetic nervous system definitely has an effect on heart rate. You know that. So here we have the heart. It has a basal rate. This one, he's probably contracting, I don't know, 50 times a minute. But let's say the sympathetic system's turned on, so now there's norepinephrine being released from sympathetic neurons innervating the SA node, AV node, and actually in the ventricular myocytes, but we'll get to those later. And if sympathetic nervous system's turned on, a sympathetic neuron is going to be activating the adrenal medulla cells, causing the release of epinephrine from the adrenal medulla that goes in the bloodstream. So epinephrine will get to the SA node as well. So what does that do? That increases heart rate. Now it's probably up to 75. So that's via beta-1 adrenergic receptors. Okay, yes, parasympathetics have a strong impact on regulating heart rate. The parasympathetic innervation of the heart is via the vagus nerve. The vagus nerve innervates the SA node, also innervates the AV node. So if you happen to have a drop, I've mentioned it several times, as you're sitting here relaxed, you're under strong parasympathetic tone. Your vagus nerve is firing. Your SA node will spontaneously depolarize about 80 to 100 times per minute. That's a faster heart rate than what you need just sitting here. So your parasympathetic nervous system, remember, that's the brakes from slowing down the heart rate. So you're under strong parasympathetic tone. You have parasympathetic discharge via the vagus nerve to your SA node. And what is it doing for you? It is decreasing your heart rate as you're sitting here. So let's look at the opposite. If you have something causing a decrease in parasympathetic stimulation, that's removing the brakes. The SA node will immediately increase its pacemaker potential slope, and you'll increase heart rate. So you have an increase in heart rate, increase in cardiac output. That can help support blood pressure. And remember, it goes the other direction. If you have an increase in parasympathetics, that will decrease heart rate, that will decrease cardiac output. Okay? You already know those things. But they play big roles via controlling heart rate and mean arterial blood pressure. Now let's look at the control of stroke volume, something you also already know. So, stroke volume is and I didn't put one thing on here, but stroke volume is primarily regulated by contractility, the preload to the ventricle, how much it fills, and the afterload. Afterload is what's the aortic or the pulmonary trunk arterial blood pressures, because that's what it has to pump against. The higher the afterload, the lower the stroke volume. But contractility, that's that ventricular ejection force. Increased contractility, a more vigorous, more robust, more complete ventricular ejection. Preload is how much blood do you fill the heart with between each beat. So there's venous return leading to ventricular filling. And that involves the Frank-Starling mechanism. So preload is Frank-Starling mechanism. Contractility is, well, contractility is contractility. So, contractility. This is primarily regulated by the sympathetic nervous system. Parasympathetic nervous system really doesn't do much for contractility. So, contractility, ventricular ejection force, if you have an increase in sympathetic nervous system activity, so sympathetic neurons, not only do they innervate the SA node and AV nodes to regulate heart rate, sympathetic neurons will richly innervate ventricular muscle cells. And there is an illustration in your book showing that when you have this increase in contractility, really what's happening, it's a lot of calcium effects. More extracellular calcium can come in, causing more extracellular calcium to be dumped from the sarcoplasmic reticulum. It sensitizes troponin to calcium, and there's just a number of things that are going on. And the bottom line is, more calcium more quickly, a more strong muscle contraction. And at the same time, it's also increasing the rate of the calcium ATP pumps to put it back in the sarcoplasmic reticulum. So with increased contractility utility, you have an increased ventricular contraction, more robust ventricular contraction, but you also have a more rapid relaxation, and you need that. So if sympathetic stimulation to the heart goes up, to the ventricles goes up, you have an increase in ejection force. That leads to an increase in stroke volume. That can increase cardiac output, which can help support blood pressure. This, once again, is via beta-1 adrenergic receptors. Epinephrine from the bloodstream that was released from the adrenal medulla. It's in the bloodstream. It's now going throughout the body, including through the coronary vasculature. That too will bind those beta-1s and increase ejection force and stroke volume. Okay, so this goes to the illustration that I gave you for the example questions. That this is very much out of your book. This line right here is just indicating pure Frank-Starling mechanisms. If you fill the ventricle with more blood, more preload, you're going to get more stroke volume. Contractility is going from here to here. For any end diastolic volume, you have an increased stroke volume, meaning you have a more vigorous contraction.
I have a question about the sympathetic and parasympathetic. So are we like constantly getting parasympathetic like all the time, and then like when we need our heart rate to increase, sympathetic just outweighs it?
Yeah.
And like vice versa, or is it like
It's always a balance. There, at any given time, there's some parasympathetic outflow to the body and there's some sympathetic. As you're just sitting here relaxed, your parasympathetics are much higher than your sympathetics. So you're under what's called strong parasympathetic tone. When it's said that you're under parasympathetic tone, it means they're predominant.
okay.
But let's say you become anxious. Let's say our site visitors come in and decide that they want to come in and ask you some questions about what we're going over today. You might switch to sympathetic tone. Your parasympathetic rate would go down and your sympathetic outflow would go up. So there's always a dynamic balance, and you generally are in one when you're at rest, and then when you're preparing for action, the fight or flight, parasympathetics go down, sympathetics go up. So there's this and once again, they tend, in a normal healthy person, and even in sick people, they're inverse to one another.
Right.
When one goes up, the other one goes down.
If you were to move from like Y to X, would you have both contractility and Frank Starling in play?
For going from where?
If you go from like Y to X, because now you're going up between the two, but you're also going up the line. So could you have
If you
both?
go from Y to X, yeah, anytime you go from this line up, there's contractility. Anytime, if you go along here, that's Frank Starling. If you go in this direction, it's Frank Starling. So if you go from here to here, you have two things going on. An increase in Frank Starling, increase in preload, and also an increase in contractility. Yeah?
You can still consider Frank Starling in the reverse direction?
Yes, thank you for saying that. Frank Starling goes in both directions, and contractility goes in both directions too. Because if you go from Z to Y, that is a Frank Starling effect. It's just that there's decreased preload leading to a decreased stroke volume. So Frank Starling is what's happening to preload. Is it going up? More increased stroke volume. Is it going down? Decreased stroke volume. So I'm glad you asked that. So if this is your set point, if it's going this way, it's going that way. Either way, along this line, this is the preload. Well, this is preload too. But anytime you have this displacement going up, that's contractility. So you can be up here. You can be up here and go down to there. What's that? Decreased contractility. So when you go up, it's increased contractility. When it comes down, when you slide along this line, it's increased preload. If you slide this way, it's decreased preload. Doesn't matter which line you're on. Okay, so contractility is very important for stroke volume, and I wish I would have left this illustration on here, but preload is very important for stroke volume. So preload is your ventricular and diastolic volume. How much blood did you preload into that ventricle prior to systole? And as you increase preload, you have better thin and thick filament overlap. As you increase preload, you sensitize troponin to calcium. As you increase preload, there is a slight increase in release of calcium from sarcoplasmic reticulum. So let's say Z is a person's normal. If you load the ventricle with more blood, well, your preload is going up, more stroke volume. If you have less loading of blood into the ventricle, that's decreasing preload. That's decreasing preload, and you'll have a lower stroke volume. So, preload is really set by venous return. More venous return, more filling of the ventricle, less venous return, less filling of the ventricle. And yeah, this is the Frank Starling mechanism. So there's really two primary determinants of preload. And one is venous compliance, and the other is just how much plasma volume do you have. So remember your veins. The last thing we talked about last Thursday was your veins can just kind of bag out. They accept a huge amount of volume. Veins are low compliance. A very low change in pressure causes a big change in volume. They will just bag out. But during periods of sympathetic nervous system activity, yeah, they have alpha-1 adrenergic receptors and they stiffen up. And when they stiffen up, what does that do? Because here in the venous system down here, you have one-way valve. So if they stiffen up, blood can't go back that way, it has to go that way. So if you have a decrease in venous compliance, that's going to increase venous return, that will increase preload, that will increase stroke volume.
So increasing that pressure.
Pardon me?
So you're increasing the pressure, you said?
Yeah, you're increasing venous pressure. That's exactly what's happening. So if this down here so your right atrium, it's at 0. So you know what? You don't need to go very high up. Right down here, it's 2 or 3. If that venoconstriction goes to 4 or 5, that's a huge increase in gradient because you're going against essentially 0. And actually, during an inspiratory effort, it drops to a -1. So it's just pulling blood in there. Now, I think you can probably understand if somebody, for example, is very much oh, sorry, Kim.
Can you use like a different word for compliance, like say it in another way?
And say what?
Say compliance, like what it means in another way?
So compliance is a change in volume for a given change in pressure, okay? So a compliant individual, you make a suggestion, they accept it, and because compliance means yielding the pressure, okay? So, these blood vessels, imagine this, and I usually bring this into the respiratory. A bread bag. A bread bag, you can squeeze it down enough and very little pressure, and it blows right up. It has very low compliance. Small change in pressure, huge change in volume. You take a balloon, you have to have a much higher pressure to get the equivalent change in volume. That is a much lower compliant system. So compliance is yielding to pressure. Yielding to pressure. And that's what these veins do. They yield and they bag out. But under sympathetic stimulation, they will stiffen up. They don't really vasoconstrict like an arterial does. What they do is they just aren't as baggy. And that helps drive the blood back to the heart. So this is change in volume for a given change in pressure. And typically, veins are high compliance. Arteries are low compliance. So if you are dehydrated or if you suffered a hemorrhage, I think you can understand that if you have this drop in plasma volume, you're going to have a drop in venous return, a drop in preload, a drop in stroke volume. So, one thing that the body tries to do is you can have an increase in water retention at the kidneys, and if you increase water retention at the kidneys, that will increase stroke volume. So I would make sure that I write both of these just opposite. An increase in compliance causes an increase in, a decrease in venous return causing a decrease in stroke volume. If you have a loss of water in the body, that's going to decrease venous return. That's going to decrease stroke volume because, just we were talking about parasympathetic, there's this, both of these, it just goes one way or goes the other. Okay? So, let's look at, here we have a very baggy inferior vena cava, okay? There are alpha-1 adrenergic receptors on that inferior vena cava. So, what happens when your sympathetic nervous system is activated? There's this release of norepinephrine from sympathetic neurons that innervate these great veins. And so it goes from baggy to just kind of stiffer and more rigid. And because we have one-way valves down here, blood can't go, stiffens up. That's going to pressurize the blood just a little bit. It can't go that direction, so it has to go that direction. Has to go that direction. So that's what would happen if we have an increase in sympathetics. So, but if we started in this position and sympathetics turned off, guess what? We go to this baggie. Just goes my direction. This is angiotensin II. Very powerful vasoconstrictor. I just briefly mentioned it one time before. On a molar basis, it's the strongest vasoconstrictor produced by the body. And there are angiotensin II receptors. And you know, before I go on, yeah, we're talking about preload and so forth, but remember, we also have these alpha-1 adrenergic receptors on the arterial side as well. Well, here we're on the venous side, and we're looking at how we can get blood to get back to the heart, to preload the heart so we can regulate stroke volume. Well, you have angiotensin II receptors, and they are powerful vasoconstrictors. You also have angiotensin II receptors on the arterial side too. So they would increase mean arterial blood pressure on that side. So both of these going in this direction would increase venous return, increase ventricular filling, increase cardiac output. What if sympathetics went away? What if you gave a drug, an angiotensin II receptor antagonist? Yeah, and you will be prescribing these things, ARBs. If you cover up that receptor so that agonist can never get to the receptor, guess what? You stay in this situation right here. That decreases venous return, that decreases blood pressure.
So are arteries lower compliance because even though they expand, they recoil? Whereas
It
they
takes a much,
expand and they don't
so
recoil?
they're much more like that balloon. It takes a lot of pressure to get a change in volume.
Yeah.
But because of that, yes, they then can snap back driving blood.
Okay, and they just don't do that because they don't have much
They don't
elastic
have
tissue.
nearly as much elastic tissue.
So they
have-
kind of just extend and stay.
They descend and they
I mean,
just
not
kind of
both,
glide
I
back,
guess,
they
yeah.
don't snap.
Okay.
Yeah.
When you talk about filling, is that the speed of the filling or the amount of both?
It can be both, but it depends on your heart rate, because if you have a slow heart rate, you simply have more time to fill. And so that is, you know, a trained endurance athlete. You're sitting next to a half marathon here, okay? When Andy was ready to run that half marathon, when he was in bed, those last, lying flat, getting ready to fall asleep, his heart rate was very, very low. And, you know, it might have been chugging, what, 45, 50 beats a minute? Did you ever check that? Okay. But within limits, the slower your heart rate, the more time you have for ventricular return, the more time you have for ventricular filling, and the higher your stroke volume. So, highly conditioned people who have slow heart rates, they still have equivalent cardiac outputs at rest as you, well, as me or some other unconditioned person. It's just they're doing it in fewer beats. So a slow heart rate gives them more time for ventricular filling. And because they have a very powerful contraction apparatus, they can utilize that to inject more blood. So there is kind of a fine line. You can have heart rates so fast that it will limit ventricular filling.
That's what I asked, if your heart rate's beating fast.
Yes. You know, heart rate in humans is when you're young, when you're in your teens, it's usually about like 220. And there are ways you can push it a little bit higher, but cardiac output doesn't really go up because it's beating faster than what it can take in for venous return. So even though it's beating faster, there's no gain. So we're engineered correctly so that when you're young and your heart can relax very rapidly and contract very rapidly, yeah, you can have a high heart rate and get blood in and out very quickly. As one gets older, heart rate starts going down. Guess what? The relaxation rate goes down. It takes unfortunately, you can't fill as much between beats. So my max heart rate right now is 171 measured. For my age, it should be 165. I'm a little bit above. Anyway, but bottom line is if you artificially raised it above, you wouldn't increase my cardiac output because my heart cannot relax as quickly as yours can for ventricular filling because of aging. My heart's becoming less compliant. Your heart's more compliant than my heart.
How do you measure your max other than like doing it by calculating your age? Where you say you actually measured.
It was during a maximum work protocol.
Okay.
But a lot of you will do what are called, there are maximum stress tests where you put somebody on a cycle ergometer or a treadmill. You can do that with people who are physically active, but most of what you guys will be doing will be a pharmacologic max test where you hit them with adrenergic agonist and their heart rate just goes up incredibly high. And while they're lying still, because some people, they have such poor fitness that their legs will give out, will be the limiting factor before you see what the max potential of their cardiovascular system.
Is that the stress test?
Yeah, they're both called stress tests.
Okay.
There's a pharmacologic stress test and then there's a work stress test. One, you're cycling or walking, the other one, you're lying still and you go, oh, I think I'm having a heart attack. Speaking of, I think I'm having a heart attack, which gets to you. Okay, I shouldn't take this top note. I was a sophomore in college and I used to, from the time I was a little kid, I would get a sore throat about this time of year, 1st of November, and it'd go away in March. And I mean, I'd have tonsillitis the whole time. And I was at the vanguard of, before me, the kids before me, a kid gets one sore throat, they took out the tonsils. But I was in part of the baby boom generation where, oh, the tonsils are there for a reason. Don't take them out. Don't take them out unless you absolutely have to. And not only did I have tonsillitis, man, I had strep throat so many times. And so I'd just be sick all winter long, every single year. So I get in college and it's like, I'm tired of this. It's spring break of my sophomore year. I call my back in central Nebraska physician. I say, you're either going to rip out my tonsils or I'm going to get some Yehu and down. Do it. I'll do it. Come on home and I'll do it. So, what was I, 19 years old, something like that. And I go back home and I have friends who are nurses at the hospital going, oh man, you're just going to get kicked. Taking out tonsils in somebody who's not a kid, it's just, you're going to be surprised. Oh, no way, I'll walk out of the operating room, no problem. It's not a big deal at all. Anyway, I go in, I wake up in the operating room, face down, there's a little bit of blood, I look up, and I happen to know the nurse said, is it over? You're not supposed to be awake yet. Well, I'm ready to go for a run. I said, oh, well, you better turn over and relax a little. Yeah, they pulled me out of the ER. My mom was there, and one of the nurses' friends, she was there. I said, I told you, I was just going to walk right through this. And, well, you're right, you might. Well, I go back in the room, and after 10, 15 minutes of talking to people, I think I might take a nap. I'm actually tired. I take a nap for 90 minutes, and I think my friend came in with a sledgehammer and hit every inch of my body. I woke up, and from my earlobes to my toes, I heard. And I'm like, she comes and takes my blood pressure. She says, I knew. Anyway, that's my inside manner. And there was a kid who had his tonsils out just right after me. At this point, he's running up and down the hallway screaming, I'd kill him. And I heard. Anyway, so a couple days go by, I'm at my mom's place. Blood clots break loose, which happens all the time, from the wound. And unfortunately, the blood clots came off in a big mass and it went down and all of a sudden they went, and I've been kind of bleeding because I had part of the clot was coming off, and I was bleeding. My mom's going, well, this doesn't look right. Oh, so I knew I was going to bleed a little bit. And she says, you know, this isn't right. This isn't right. Small town. I'm going to call the rescue unit. We're going to take you up to the doctor to make sure everything's fine. Everything's, and all of a sudden when I'm talking, I popped off clots, and they went down and they jammed, on my trachea, and it's like, I'm not breathing, and I can just feel blood building up on there. And my mom's on the phone. Yeah, Larry's bleeding a little bit. Maybe. And it's like, I've got to do something. So I nothing. Nothing. It's like, well, need to be a little more vigorous. So I'm looking, there's a kitchen sink. I slam into it. Nothing happens. And at this point, my vision's really starting to close in. And blood's coming out of my mouth. So I hit it hard. And boom! Out comes all this blood, out comes the clot. And I literally sink to the floor. And within seconds, guys who were EMTs who got the call, they're already at the house. And because one just lived across the road, he was one of them that got the call. And he comes over, hey Larry, how you doing? And he says, why are you sitting on the floor? And I'm leaning up to the sink, and because there's blood everywhere. So they get me to the emergency room. I'm going to get to the point of the story. And there's this old crusty country doctor. I really, really love the guy. He was just a nasty old dude to most people. I just thought he was great. He was just brusque. He goes, my gosh, you blew holes in your throat. We're going to have to solder those shut. He's going to cauterize it. And he's opening me up, and he says, there's so much blood in here, and every third word he's saying is blue, right? And I can't see anything. So he's calling for, give me some of that epinephrine, lidocaine with epinephrine. And so he loads up a syringe, and he's squirting it onto these open wounds in the back of my throat. And so what that's going to do, it's going to give me some anesthetic action so he can cauterize and I won't jump off the table. And that epinephrine is going to cause vasoconstriction. So this all fits. It's going to vasoconstrict so he can see the field, so he'll know where to cauterize. So he's given me some, and every time he'd cauterize, it'd break open. So he'd squirt a little bit more, he'd cauterize a little bit more, I'd break open, now I'm breaking open on the other side. And I've got a pretty good gag reflex, so he's got his big paws down there, got suction down my throat, and he's squirting more and more of this stuff in. And I'm just going, something bad's happening, something very bad's happening. And I start trying to talk to him. It doesn't work if you don't. And he finally pulls out, what? I think I'm having a heart attack. Because I'm looking up at the clock, and I'm going, my heart rate's at least 240. And this is something that I never want any of you to do. This is one of the points of my story. He looks at the vial that he had taken this of, and he says, blank, 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 and throws it and hits the wall. And I'm thinking, great! He gave me something, I'm poisoned, that wasn't the right stuff, I am having a heart attack. This is it. It was a good run. I was going to be 20 in a couple months, it was good while it lasted. He says, well, hang on, cowboy, I've got to do this without drugs now. So burned flesh is one thing, but when it comes up from the backside of your nose, it's pretty impressive. He was giving me, and afterwards, when things calmed down a little bit, and cleaned up the blood and so forth, he says, that's the stuff that you give with dental injections. It's lidocaine and epinephrine. And bottom line is, I gave you too much of the epinephrine because I was squirting into an open wound and it was just going into your bloodstream. And every time you popped open, I squirted a little bit more. So I'm going, oh, you didn't poison me? Well, hell no, I didn't poison you. I just might have overdosed you a little bit. And then it happened again in the middle of the night. I stayed in the hospital and it happened again in the middle of the night. So we went through it again, but this time be easy on that stuff, I can take the pain. Don't start that stuff in me. Okay, so my heart rate was like 240, and my heart was working so hard for that heart rate, but I was having, wasn't really chest pain, but I knew something wasn't right. So my heart rate was actually at a rate that it wasn't doing any good for supporting more additional cardiac output or coronary artery blood flow. So there is a limit to it for being effective. So, okay, so sodium intake, you're going to see more of this when you get to renal. If you take in a lot of sodium, that will also cause water retention. Water follows sodium, and that will cause an increase in venous return, increase cardiac output, and that can increase blood pressure. So, and remember, all these go the other direction. If you have an older person with clinical hyponatremia, low blood sodium, it goes in the other direction. This has happened to my mother twice, and blood pressure goes down, and you don't do very well. So the name for low blood sodium is hyponatremia, N-A-T-R-E-M-I-A. So remember, draw in the arrows just opposite of all these, because it goes in the other way too. So you also have baroreceptors in other areas of the body. The only other one I'm going to talk about, it's in what's called the afferent arteriole of your kidney. You have baroreceptors right there, and this is the slide that I gave you. But when the blood pressure in the afferent arteriole drops, that turns on what's called the renin-angiotensin-aldosterone system. This is really an emergency system for releasing angiotensin II and aldosterone. So this is really kind of an emergency system. So you have this, the liver releases this molecule called angiotensinogen. It's not active at all as a vasoconstrictor. But it has to be converted to angiotensin I before you can get in the cascade of making a vasoconstricting drug. And your kidneys will release a protein called renin. It's not renin. You use renin for making cheese. It's renin for the renal system, okay? This renin, what does it do? It chops off a couple of amino acids from angiotensinogen, and in the bloodstream it converts it to angiotensin I. Very weak vasoconstrictor. But this angiotensin I goes through your bloodstream and in your pulmonary capillaries. When it's going through your pulmonary circulation, on your pulmonary capillaries you have what are called, you have ACE, angiotensin converting enzyme. Imagine kind of like a balloon on a string. This enzyme is tethered to the vascular wall, and so as this angiotensin I goes past this ACE, this angiotensin converting enzyme in your pulmonary capillaries, it cuts off an amino acid or two, and you now have full-blown angiotensin II, which is a powerful vasoconstrictor. Powerful vasoconstrictor. It will vasoconstrict on the venous side, increasing preload, increasing stroke volume. On the arterial side, it's also a powerful vasoconstrictor. So that in and of itself will increase total peripheral resistance, the other element of that blood pressure equation. Angiotensin II will also bind its receptors. So there's angiotensin II receptors on the vasculature. There's angiotensin II in your adrenal cortex. And when angiotensin II binds that, you have the release of aldosterone. And aldosterone is a steroid hormone that in your kidneys, it causes your body to, rather than letting sodium go out in the urine, it reclaims that sodium and puts it back into the bloodstream. It causes sodium retention, water follows it, So rather than losing a large urinary volume, you retain a lot of the water, and that will over time increase plasma volume and preload. Yes?
Can you say again what angiotensin II is binding to?
Angiotensin II has its own receptors.
Okay.
So there's angiotensin II receptors on veins, on arteries, and also there's angiotensin II receptors here in the red part of the adrenal gland, and that's called the adrenal cortex. So it's doing a couple different things. So if your blood pressure goes down, that RA, that's your renal afferent arterial blood pressure drops. That'll turn on this cascade. If your blood pressure is dropping, your sympathetic nervous system will turn on. That also turns on this cascade. And two elements to this cascade. Now, I should mention this. Well, I'll get to it in another slide. But this takes a little time to turn on. To turn on this angiotensin II vasoconstriction, it takes minutes, and it's not fully operational for a couple hours. For this aldosterone effect, it takes hours to start it, and it isn't fully operational for days, but it lasts a long time. So I think this is the slide that you have. So when you activate this renin-angio-aldosterone cascade, you can help support blood pressure in a number of different ways. Very powerful mechanism. This is the way your book shows it for vasopressin. In your atria and other areas, you have other baroreceptors. Yeah, I guess there's one other set of baroreceptors. And they cause the release of a hormone called vasopressin. Vasopressin is released from the posterior pituitary. So the example in your book is they show if you have a decrease in plasma volume, that's going to cause a decrease in venous pressure. And one thing it does is decrease preload will cause decreased stretch on the atria. And it's other places as well, but in your atria you have baroreceptors, and if you have decreased venous return, you're going to have decreased atrial stretch. You have a neuron that goes from your atria up to your thalamus, and it will stimulate a neuron that goes to your posterior pituitary, and you'll have release of vasopressin. So if venous return is, though this is going the other way, if venous return is increased, baroreceptor activation located in the atria increases. This causes neural activation of the hypothalamus, causing a reduction of the release of vasopressin. This reduces vasopressin-induced vasoconstriction, lowering blood pressure. It goes the other direction as well. So we have baroreceptors constantly looking 24/7 at blood pressure. So now let's look at this part of the equation, the total peripheral resistance. The vast majority of the regulation of total peripheral resistance is by arterial vasoconstriction. You're either vasoconstricting or you're vasodilating, or something in the middle. Yeah.
So this is going back to the previous. So every set of baroreceptors, they do one specific thing?
Yes.
Okay.
Yes, so your aortic, your carotid sinus and aortic baroreceptors communicate directly with your brainstem blood pressure receptors. The renal artery baroreceptors regulate the release of renin. And the baroreceptors associated with the release of vasopressin, they will communicate with the hypothalamus, which will send a stimulating or an inhibitory message to the posterior pituitary, release vasopressin and not release vasopressin.
And that's from the atrial wall.
Atrial stretch, but your book does go into more areas. It used to be thought that the atria were the only ones. Turns out we have a lot of these baroreceptors that are associated with regulating vasopressin release. Okay, so the last part of that equation is this TPR, total peripheral resistance, and that really has to do with arterial tone. Are you vasoconstricted? Are you vasodilated? Are you something in the middle? Okay? You already know that you have alpha-1 adrenergic receptors on arterioles. So, and you know, I don't want to forget to mention the local vasodilating mediators. The local mediators, they all cause vasodilation, but here we're going to look at regulation of the sympathetics and the angial system. So here we have an increase in sympathetic nervous system activity is going to cause release of norepinephrine at these arterioles, and there are alpha-1 adrenergic receptors. And remember, working through an IP3 signal transduction process leading to increased calcium leads to smooth muscle contraction. So that's what happens when norepinephrine binds that receptor, it causes vasoconstriction. And that vasoconstriction will cause a very large increase in total peripheral resistance. That increases blood pressure, mean arterial blood pressure. It goes the other direction. If you have a decrease in sympathetic, you'll have less vasoconstriction, less total peripheral resistance, more vasodilation. Okay, now, once again, this renin-angio-aldo system, it's involved here. So on a molar basis, this angiotensin II is a powerful, powerful vasoconstrictor. Once again, it goes in the other direction. If there's less angiotensin II in circulation, your total peripheral resistance will go down. All of these are bidirectional. And the thing to remember, resistance is proportional to 1 over radius to the 4th for the diameter of any tube, including your blood vessels. Yes?
So it's not really acting as a vasodilator? It's
It
just-
does, you know, there is arterial tone. There is basal arterial tone. So vasoconstrict like that, or if you're in that position right there and then you let off on sympathetics, you go back to basal, but you're not exactly vasodilating. So once again, vasoconstriction, vasodilation, something in the middle. It's always sliding one way or the other.
So if you wanted vasodilation, you would.
For vasodilation, what you need to remember with that are those local metabolites. Local metabolites cause vasodilation, and that reduces total peripheral resistance.
What if you bound a beta-2 receptor?
You don't have beta-2 adrenergic receptors on your arterioles. Well, take that back. On skeletal muscle arterioles, you do have some beta-2s. On skeletal muscle, you do have beta-2s. It turns out epinephrine binds beta-2s a whole lot better than it binds alpha-1. So in certain skeletal muscle blood vessels, you have both alpha-1 and beta-2s, and during slight sympathetic stimulation, the epinephrine effect predominates and you get vasodilation, and with strong, you'll get vasoconstriction. But remember, when you're exercising, you're producing all these local metabolites. The local effects always win out over the autonomic effect, because the local tissue knows best. If it's metabolically active and producing CO2 and adenosine and oxygen's going down, you'll get vasodilation.
So most of your beta-2s are located in.
Pardon me?
Where are most of your beta-2s?
Most of the beta-2s, bronchial smooth muscle, and also in your GI tract. So bronchial smooth muscle, GI tract, and some skeletal muscle arterioles. That's about the only place where you're going to find a population of beta-2s. So let's kind of step through what happens with hemorrhage here. So we have a significant hemorrhage here. Let's say somebody suffers about 7% of a person's body weight is accounted for by blood. So let's say somebody has a significant hemorrhage, they've lost maybe 20% of their blood. Well, their plasma volume's gonna go down, obviously. So if your plasma volume goes down, what's that gonna do to venous return? It has to go down. Less blood in circulation, there's gonna be less blood now in the great veins, so venous return is gonna go down. So less venous return with this rapid, significant blood loss, which, yeah, that can happen, you're gonna have less preload of the ventricle. That's gonna cause a decrease in stroke volume. That's gonna cause a decrease in cardiac output. So very soon, you're going to have a decrease in blood pressure. This can happen almost in real time with a significant blood loss due to, for example, you have an arterial laceration. So here we have a hemorrhage, we have a dropping blood pressure. The body's going to try to do something about it to keep blood pressure from falling more than it has to. Blood pressure is going to fall, but let's limit how much it falls. So right off the bat, the first thing that probably happens is with that falling blood pressure, those aortic baroreceptors and the carotid sinus baroreceptors, they sense this dropping blood pressure, so there is a decrease in baroreceptor nerve firing rate. And what does that do? That causes a reflex increase in sympathetic nervous system activation. And actually the first thing that will happen is you'll have a very rapid decrease in parasympathetic stimulation. Both of those things working together, that's going to increase heart rate. That will increase stroke volume from what it was before this happened. I mean, it's low. It's not going to increase it to what it was when the person hadn't had the accident. It's just going to try to either mitigate it or get it better than what it was just seconds before. Bottom line, that's going to help drive up blood pressure. It's going to help drive up blood pressure. And remember, the sympathetics will even cause vasoconstriction of arterioles. Your body really, really, really wants to keep your heart and your brain perfused. Things like your skin, your gut. There's kind of a pecking order that you will have vasoconstriction and decreased blood flow to your skin very rapidly. And you'll see people turning pale. Well, decreasing blood flow there leaves blood for other areas. Well, if the hemorrhage is even more significant, there'll be a decrease in blood flow to the gut, okay? And you kind of go on down the line. Then there might be a decrease in blood flow to the kidneys. That's an iffy thing. If you decrease blood flow enough, you'll start getting to failure of some of your filtering units, and some of those never come back once you shut them off. So you're edging toward kidney failure. But what's your body trying to do? Preserve blood flow to the heart and to the brain. So it'll sacrifice blood flow to other areas first. So that sympathetic stimulation will end the drop in blood pressure. Both of these things, you're going to have two different signals telling the afferent arterioles of the kidney to release renin. Renin will go into the bloodstream and convert angiotensin 1 to angiotensin to angiotensin 1. All angiotensin 1 has to do is go through the pulmonary capillaries, and because ACE is there, it'll convert it to angiotensin 2, and that'll cause powerful vasoconstriction. Now, up here, this baroreceptor response, this only takes minutes to activate, and you know, I say that it'll last, this is how fast it is to activate, and this is how long it'll last. Everybody talks about blood pressure control with baroreceptors, but they give you short-term blood pressure control. They might help support blood pressure for 48 hours, something like that, and then they start adapting. Now this, with angiotensin II, it might take hours to get this fully activated, but it can last for days in helping to support blood pressure. And the angiotensin II, it's gonna do another thing, it's gonna cause release of aldosterone. That's gonna cause sodium and water to be reabsorbed from the kidney and not released in the urine, and that helps to support blood pressure. This takes a couple days to really hit its maximum, but it can last for weeks. So, this is why it said that short-term blood pressure is very often a baroreceptor response, but medium and long-term blood pressure requires the kidney. Absolutely requires the kidney. So you think of the kidney doing a lot of things for you, but blood pressure control, you don't always just think, oh, that's what the kidneys do. Kidneys are central to long-term blood pressure control, especially mid and long-term blood pressure control. Now, once you start restoring your volume, if that person is able to drink fluids or being infused, you're going to help restore plasma volume, and then everything will start shutting down. Everything will start shutting down.
So, with the renin-angiotensin aldosterone system, does that also go backwards? Like if over a few hours or days you have higher blood?
It just turns off.
Okay, so it'll
Yeah,
just.
imagine this as an alarm system. If blood pressure is really low, it turns on. If you get blood pressure back to normal, you just stop the release of renin, and everything downstream starts going away. Not immediately, but over
And
time.
if we get, in the case now that, like, I guess most people, let's say if they're bleeding, you know, something happens big and they're losing a lot of blood, we get EMS, we send them to the hospital. Within, I mean, a couple hours, they be now pretty much replenished with
Exactly.
fluids. Could it be that like a lot of times maybe this like long-term system may not even be activated because we have already, or?
Well, this will probably at least be starting to be activated.
Okay.
Yeah, it's probably started. Also, think about, ADH is the other word for vasopressin, so think of what vasopressin would do. ANF is atrial natriuretic factor, don't worry about that one for right now. This is how your book describes it, so please look at 1259 carefully. And this is 1261, and I really like this because this is showing what reflex compensation does. It doesn't get you back to your normal stroke volume and your normal cardiac output. It just gets you better than what you were before compensation. Now, something that I didn't mention about here is what's happening with capillary fluid dynamics. Remember, that's the filtration forces versus the reabsorption forces. If capillary hydrostatic pressure drops, what happens? Filtration forces are reducing. Reabsorption forces are going to stay the same. So what's going to happen? You're going to have a net reabsorption. So one thing that happens during a hemorrhage is because you lose one of the filtration forces for capillary fluid dynamics, you're going to have less filtration, so reabsorption is going to predominate. And that can actually make a difference. About 1 liter of fluid per hour makes a big difference. Fluid's actually leaving the cellular space and going into the extracellular space.
Is that what like the book was talking about, instead of going into like the capillaries diffusing out and doing all that, it just starts like bypassing and shifting from like the arterioles into the.
Oh, going
like,
through
just-
med-arterioles?
Yeah, it just kind of
That's,
does like
that's
this
kind of a
filter.
different thing. That's kind of a different thing, and that's in very specific vascular beds. A little bit different. It would happen, but not in all vascular beds. What I'm talking about is with the Starling forces equation, you have one pushing force, capillary hydrostatic pressure pushing fluids out. You have one pulling force, proteins drop fluids out, and on the reabsorption side, you have tissue hydrostatic pressure driving fluid into a capillary, and you have capillary proteins pulling fluid in. If your capillary blood pressure goes down, filtration forces go down, so the balance goes toward reabsorption rather than reabsorption and filtration balance. So, I will see, those of you who want to go through this cardiovascular questions, I'll try to get here as soon after 1 o'clock as I can.
Yeah.
Usually go.
Or you just do yourself. That's what they do, that's what they do.
I went through with like yesterday, at the end, like really hardcore.
I'm not gonna go there, you know, I'm not gonna go there, right, because there's so many different types of kidney failure. Boy, that's a loaded question. I am not really qualified to talk about. If they have a hemorrhage? Okay, yeah, we'll get to it. Yeah, if somebody. That's exactly right. That's exactly right. So we're going to look at